to invite Ala Alwan to give a talk today. The format this evening, as you can probably tell from the comfy chairs, is that Ala's going to speak for a while about his experience about attempting to address the global problem of non-communicable diseases. And then we're going to have a facilitated discussion with a panel of a fellow, a JRF, and a couple of students. And then we're going to open it to the floor for further discussion. So as I'm sure he's going to tell you, Ala's a good friend of Cambridge, and I think his first slide will indicate that. But he's been a frequent visitor here for the past year, not possibly for academic interests, but mostly because his daughter and son-in-law have been here on a sabbatical for the past year, and he's been here with his wife on grandparent babysitting duties. So the family, en masse, are very much a part of the Cambridge family. It's great to have you here tonight and to welcome you to speak as part of the Wolfson family. So, Ala.
Well, thank you very much, Nick, and it is really an honor and a pleasure to speak here again. It's also, as you said, great to be in Cambridge for a number of reasons. But one of the reasons is that Cambridge had a very important influence on my professional career. And the story is this, that very early in my clinical career, I am an internist with an interest in endocrinology and diabetes, and very early in my professional career, I was invited by WHO and the International Diabetes Federation to a seminar on the public health aspects of diabetes. That was the first international seminar organized by the two agencies on the public health aspects of diabetes. This was really when I got more interested in public health. So for me, this seminar was some sort of a transformation that had a lasting effect on my professional career. So thank you so much for inviting me back to this great institution. What Nick asked me to do is focus on the experience in addressing the global challenge of non-communicable diseases. He asked me to speak for about 25 minutes, and then we go for a panel discussion, which I'm very much looking forward to, and hoping also to learn from you. And so I thought in the 25 minutes, I should maybe focus on a number of messages, maybe 4 messages. The first 2 or 3 messages, by the way, this is the first public health or first international seminar on public health aspects of diabetes. And there are a number of people here that Nick knows very well, between students and also faculty. It was very difficult, actually. Too many people here, and it's not very clear. But I'm in the back. Yeah, and so the 4 messages I wanted to focus on are related to my work at the World Health Organization and my work in what I call the journey, or the WHO journey or the UN journey to address non-communicable diseases. And I call it a global journey because all countries were centrally involved in the different initiatives. I was privileged and actually fortunate to be directly involved in this journey for over a decade. First as the director of the Department of Non-Communicable Diseases at WHO headquarters in Geneva, and then as the Assistant Director General in charge of non-communicable diseases, mental health, and related programs. Subsequently, once the policies were set. In 2012, I was elected to the position of regional director of the WHO Eastern Mediterranean region. And so it was another opportunity for me to look how the policies set over the previous decade are implemented at the country level. So my first point, as you can see in this slide, is something that I'm sure you all agree with. And this is firstly the fact that we're dealing with a huge global health problem responsible for the leading causes of premature death, of mortality in general, but also premature death worldwide. And secondly, the established fact that this global health problem is largely preventable, but yet, unfortunately, it is not receiving the attention it deserves. This was the case when I first joined WHO, working in this area, and in some ways, it's still the case, unfortunately. So today we have about 41 million NCD deaths based on the most recent estimates from WHO. And this actually represents about 74% of all global deaths, so 3/4 of global death. What is actually important here is that around 17 million of these deaths are premature. They occur before the age of 70 years. And what is also important is that this burden, or actually the main burden, is actually in low and middle income countries. So something like maybe 85% of premature deaths are actually taking place today in low and middle income countries. This is an old slide. I used this slide in a presentation to Commonwealth countries during one of the World Health Assemblies many years ago, so the data is somewhat outdated, but the message is the same. And you can see actually this is on the deaths from non-communicable diseases, but before the age of 60, and even lower level in the Commonwealth countries. And the Commonwealth countries is contains countries that are high income and low income and middle income. And as you can see from this, the high income countries have an average death below the age of 60 years of around 10%, 12%, or 15% maximum. And the average for lower middle income countries is around 30%, and sometimes exceeding 50%. So this is a huge problem because it has an important impact on socioeconomic development. So let me come to the second message. And here we now have, we think that we now have a clear vision. We have strategic directions to control non-communicable diseases. And we think we have high impact interventions to address not only non-communicable diseases, but the risk factors that are causing non-communicable diseases. So a global strategy was agreed by all member states. I'm sure you know a lot about WHO, but WHO works through the member states. And this was in 2000, in the year 2000. And this strategy, which was endorsed more than 20 years ago, is actually the basis of all global developments to address non-communicable disease over the last maybe 20, 22 years. And the third message here, this is that we have an important contribution from the other sectors other than health. And just half an hour ago, I was discussing this issue with some of the young colleagues, and we were talking about the contribution of other sectors to health, particularly in this case to non-communicable diseases. because both the origin and the implications of non-communicable diseases go beyond health. So to tackle NCD is a really serious challenge to sustainable development, but at the same time, there is no way you can actually control non-communicable diseases or the progressive rise in non-communicable diseases without addressing the social, the economic, and the commercial determinants of NCDs and of health in general. And we know that the health sector cannot directly influence these determinants without engaging other government sectors. So it's a two-way situation. And once non-communicable diseases become firmly established, then their adverse health consequences, the negative impact on poverty, and the progressively increasing healthcare costs, they all impede development. And that point is the center of the global journey against non-communicable diseases. Because of this, it was absolutely necessary that for the global strategy and also for any initiative on non-communicable diseases to engage the highest level of government. So it's not an issue that can be discussed and solutions proposed and implemented through the health ministries and the World Health Assembly. It is much beyond this. And in this respect, there was a major breakthrough in September 2011 when non-communicable diseases became the focus of the annual meeting of heads of state and government during the first 2 days of the UN General Assembly session in New York. By the way, this was the second time when a debate on a global health problem moved from being a challenge to ministries of health, debated at the World Health Assembly every year in Geneva, to a health and economic issue for the heads of states and government discussed at the General Assembly level in New York. And the political declaration that was issued actually translated the global strategy that was developed and approved by the Assembly in 2000 into a clear multi-sectoral roadmap for all countries. An important point in this initiative is that this heads of state meeting in 2011 actually brought non-communicable diseases to become part of the agenda of the General Assembly. So it's a constant agenda item in the World Health Assembly. It has now moved to become an agenda item, a development agenda item. So as the Secretary General at that time said, it is now where it belongs. Another development that was the result, actually a direct result of the high-level meeting and the General Assembly political declaration happened in 2015 when non-communicable diseases became one of the targets, the key targets of the Sustainable Development Goals. They were endorsed by the General Assembly in 2015, and NCDs became a target, which is SDG target 3.4, which is part of the health goal of the Sustainable Development Goals. And this is what the target says, that by 2030, in 15 years' time, we only have now almost 7 years left, all countries are expected to reduce by 1/3 the premature mortality from non-communicable diseases, mainly through prevention, addressing the risk factors, and also improved healthcare and treatment. So let me come to the fourth message. And the message is that there is absolutely no doubt that the global strategy and this UN political declaration resulted in a great increase in global awareness. It resulted in considerable achievements made at the global level, at the regional level, and also at the country levels. But the progress in implementing the commitments made and the actions in the roadmap and the progress made so far made in achieving the SDG target has been very slow, inadequate, and fragmented. I'm actually using the exact words of the General Assembly declaration that was issued following the second or the first follow-up meeting of the General Assembly on non-communicable diseases. So unless the barriers to progress are clearly identified and they are clearly addressed, effectively addressed, it will not be possible to stop the increasing trend and achieve the global NCD target. And I'll try to come back to this issue if we have time at the end of this presentation and probably during the panel discussion that we have. But let me now focus on the journey to develop this global strategy. The strategy actually focused on these four major groups of NCD or non-communicable conditions. I call them conditions because not everyone is a disease. And these are the reason why the focus is there is because they are responsible for 80% of the non-communicable disease mortality at the global level. And you can see that cardiovascular diseases here are leading. They are responsible for almost 18 million deaths, followed by cancer, and then chronic lung disease, and then diabetes and its complications. We actually established some sort of a steering committee in the beginning of 1998, and the focus was actually to conduct an in-depth review of the burden and also of international experience. I have here Dr. Brundtland. She was the Director General in WHO, and she actually was the first Director General for WHO. She was the Prime Minister of Norway before moving to WHO. She was the first to give non-communicable diseases a higher priority. So she elevated non-communicable disease from just a small department into a cluster with 4 departments, and she initiated the work on the global. She asked us, the first question was to develop the global strategy, and she initiated, of course, the work on the Framework Convention on Tobacco Control, which is one of the most important UN treaties. And so she supported this work, and through this kind of in-depth review of the burden and international experience, the strategy was actually developed. These are the 4 groups of NCD conditions, which are the focus of the strategy, and the 4 shared risk factors. So cardiovascular disease, diabetes, cancer, chronic lung disease, sharing tobacco use, unhealthy diet, physical inactivity, and the harmful use of alcohol as causative risk factors. Later on, we had air pollution emerging as a major risk factor for cardiovascular diseases. So we're now dealing with 5 risk factors instead of 4. But at that time, people used to call it the 4x4 strategy. So 4 groups of disease and 4 risk factors. And the strategy has these 3 key strategic directions, or we call them components. A surveillance component, and the whole idea was to map the non-communicable diseases and their risk factors and to analyze their determinants, social, economic, and political determinants, with specific reference to poor and disadvantaged populations. And then we have a prevention component to reduce the level of exposure to the common risk factors and their determinants. And then we have a healthcare component to strengthen the management of NCDs in national health systems by developing and implementing cost-effective and equitable interventions with emphasis on primary healthcare. So we have a number of strategic directions that were based on the review of international experience. And I don't think we should, we have time to go through these. I just put some of the key ones here, but they are actually published in the global strategy on the WHO website and also published elsewhere. But these are the kinds of strategies that are the basis of action and the basis of the political declaration issued by the United Nations. I mentioned the cost-effective interventions. We call them best buys in WHO. We worked on this in 2008, 2009, and 2010, and they were launched in 2011 in a ministerial meeting. And then they were also launched in New York during the General Assembly meeting. As you can see, they include what we actually mean by best buys are interventions that are evidence-based, they are cost-effective, they are affordable, and they can be implemented in all countries irrespective of income. And so we have the 5 key tobacco control measures, which again are the basis of the Framework Convention on Tobacco Control, particularly the price increase and the taxation. They have 3 key cost-effective interventions against the harmful use of alcohol, and 3 interventions on healthy diet, and a number of interventions on 2 of the key groups of diseases that are the focus of the global strategy, cancer and cardiovascular disease. They're not enough for every country, but particularly for low and middle income countries, this was a starting point. And we have a more extensive list of the best buys because they are actually updated periodically by WHO, and you can see them on the website and as Appendix 3 of the Global Action Plan of the global strategy. So this is the journey or the roadmap. When we started in 2000 by endorsing the global strategy, we had about 5 years of extensive work on the WHO Framework Convention on Tobacco Control, which concluded in 2003 and came into effect as an international treaty in 2005. And then we had the global strategy on diet and physical activity, and a global strategy on the harmful use of alcohol. But one of the most important developments that actually allowed non-communicable diseases to shift from being a health issue, a purely health issue, into a development issue was another department within the United Nations system. This is called the ECOSOC, or the Economic and Social Council of the United Nations. They have a ministerial meeting attended by ministers of foreign affairs, ministers of development cooperation, ministers of finance, and ministers of economy. And this high-level segment meets once every year. We had an opportunity in 2009 to present the evidence linking non-communicable disease to socioeconomic development. It was actually the ECOSOC that issued the resolution asking the Secretary General of the United Nations to hold a heads of states meeting to discuss non-communicable diseases. So that's an issue, a health issue, which is one of the leading health issues that had to be actually pushed forward not by health ministers, but by other ministers through another part of the United Nations system, which is the Economic and Social Council. And then, of course, this led to the political declaration of the United Nations. This is one of the, just a slide showing some of the evidence that was presented, or the kind of evidence that was presented to these ministers during the ECOSOC meeting that took place in 2009, showing the kind of return of investment if you actually implement specific cost-effective interventions for non-communicable diseases, looking at healthy diets, alcohol, tobacco, physical activity. But there was also a number of some research initiatives focusing initially on the evidence to socioeconomic developments. So as I said at the beginning, the great achievements have been made with this kind of journey between 2000 and 2011, but we can clearly see that the kind of progress that has been achieved so far is still very slow. If we look at the number of deaths in the year 2000, when the global strategy was endorsed, it was something like 31 to 32 million deaths from non-communicable diseases, representing 60% of all global mortality. And if we look at what we have today, we have 41 million dying from NCDs, and it's 74% of. So despite all these achievements and there's so many countries that have been able to implement the commitments made by the political declaration and by the global strategy, we still have a major challenge. And these are some examples of the current challenges. So most countries are obviously not on track to achieve the NCD targets. We only have 7 years left. So premature NCD mortality is still increasing in many, many countries, basically low middle income countries. And we can see the rising rates of obesity, the rising rates of diabetes today. And we have, in this slide, we show a document that is produced periodically by WHO, which is called the NCD Progress Monitor. And this monitors the situation in every single country. We have 194 countries, member states of WHO. And in this, more than 50 countries have actually lost ground over the last 2 years. The COVID pandemic is partly one of the reasons, but it's not the only reason. It's commitment that is also a major issue. And so these countries have now fewer indicators that have been achieved if we compare to the situation 2 years ago. So there's actually some deterioration in what we see. And in this NCD monitor and also in periodic surveys that are conducted every five years, we can see some significant decline in awareness campaigns, in the implementation of the NCD surveillance best buys that were recommended by the strategy and by the UN political declaration, and also in the number of integrated NCD prevention program. So what is impeding this kind of, more effective response that we would like to see in all countries and at the global level? Certainly declared commitments are not translated into action, and there are many, many examples of this. There is actually a document that was produced to analyzing the kind of commitments that have not been translated into action at the country level, at the international level, even in WHO, and also with the development partners who are key stakeholders and the industry as well. This poor financing of national programs in low and middle income countries. This is something we see in a very large number of countries, not only affecting NCDs, but it's the same problem with health systems and with universal health coverage. And by the way, there's another global challenge, and that is universal health coverage, and has a target in the Sustainable Development Goals. And the poor financing of national programs is not allowing countries to even implement the most basic and the most cost-effective interventions for a number of challenging global problems, but NCDs are on the lead for this. The low priority, the weak health systems, I mentioned in relation to UHC, and the low priority to NCDs in development assistance for health. Many development partners are not still very much convinced that this is a priority for their own mandates. But maybe, this is also related to the competing interest and also to the kind of trying to, because this issue is actually also related to the competing interests. And so when certain interventions have an impact on economy or on trade or on businesses, you also have a major influence on how some of these development partners are actually defining their own mandates. So competing interests and opposed forces are an extremely important area if we really want to address the impediments to progress. And we also feel that monitoring of commitments has to be stronger, it has to be strengthened, and has to be elevated to the high policy maker levels, to the highest government authorities. And finally, my last slide is on the way forward. We think that the next high-level meeting, we've had 3 high-level meetings so far, 2011, a follow-up in 2014, a follow-up in 2018, and the next one is in 2 years' time. So we feel that this high-level meeting of the General Assembly will be a great opportunity to reinvigorate national commitments and to reinforce global action. But this can only happen if it is if the planning is stronger and if there are intensive preparations started as soon as possible. There is a need or a pressing need for an in-depth assessment of the gaps in response, including the financing issue and an assessment of the options to address them. And we need to definitely harmonize the national efforts and integrate the NCD basic interventions with the universal health coverage agenda and with the pandemic preparedness initiatives. These are the 3 critical global challenges with universal health coverage, and we know that half of the world population has no access to essential healthcare today, and the NCDs, and we've been talking about NCDs, but also on pandemic preparedness and response. And the example you all know is the preparedness to COVID and how the different countries, even low high-income countries, were responding to the COVID pandemic. It is important to mobilize the civil society. At the global level, we've had a great support from the international civil society, including the NCD Alliance and the UICC and other very powerful global civil society organizations. But at the country level, this has been weak and it needs to be mobilized. And finally, it would be extremely important to review the commitments by the industry. We used to do roundtable meetings with the industry. Of course, we don't deal with the tobacco industry, but WHO, of course, works closely with the diet and nutrition industry, and also with the drug industry. And so these kinds of commitments that have been made but not fulfilled have to be reviewed, and maybe an accountability framework is also established. I think I'll stop here, and I am very much looking forward to the discussion part of this meeting. Thank you. I got that?
Great. So whilst the rest of the panel join Ala on stage, that's your cue, let me introduce them. So from the left is going to be Tolu Oni, who is a professor here in global health, head of the NHR Global Health Group in my unit, and is a fellow of this college. So welcome, Tolu. To her right is going to be Lambert Tata. So Lambert is a physician originally from Cameroon who's currently doing a PhD on active transport policies in low and middle-income countries. Next to Ala is Anna Brugelet-Panes, who's doing a PhD on sustainable agricultural systems in low and middle-income countries. And on the far right, in a physical sense only, is Tom McCoy, who's the head of our Science Society here, who's an Oppenheimer research fellow and a JRF, and works as a postdoc in chemical engineering and biotechnology. So we have various questions to discuss and chat with Ala about, and he's spoken mostly about his health roles, and they were very senior, Assistant Director General at WHO and Regional Director in the Eastern Mediterranean region, but he hasn't spoken about his national level roles, and some of those have resulted in an interesting tension between science and policy. So Tom, do you want to kick off with the questions about that? So you're up first.
Oh, thank you, Nick. Yes, that's what I wanted to ask you. Thank you, Ala, for the very nice talk. So I understand that you were formerly the Minister for Education and the Minister for Health in Iraq during what I hope you don't mind me saying has been a fairly tumultuous time politically in the country's history. I was just wondering if you would be open to discussing that a bit and what you felt were the major resistances to the implementation of positive change in areas such as non-communicable diseases in those roles. Thank you.
So thank you very much. Yes, it's a big question. So I actually became Minister of Health. I interrupted my WHO career in 2003 because following the change in government in Iraq in 2003, I was asked to be the Minister of Education, and at that stage, Iraq was emerging from 13 years of severe sanctions, probably the most severe sanctions in the world. I mean, at least imposed by the United Nations. And then we were also emerging from a number of wars, including the 2003 wars. And following this kind of war, we had about 80% of the educational institutions looted and destroyed. And the idea was that I could maybe provide a contribution in reconstruction of one of the most important sectors in development, because I've always believed that, for development, the two critical sectors are education, number one, and health. And so it was a huge challenge trying to start a school year. And we were actually appointed just 3 weeks before the start of the school year with no educational facilities. And actually, out of the 280,000 employees in the Ministry of Education, there were only about 1,000 who were actually working, and the rest were at home. So it was a huge challenge for reconstruction. We managed to move forward in this, and we managed to address the gaps together with a number of very effective development partners. And we managed to have a successful school year. And one key principle that we followed at that time was to depoliticize education, because prior to this, politics was everywhere in the education system. And I think that was the critical factor that enabled us to have a successful school year that year. And so I mention this because politics have not had, apart from this year, maybe the first year after the change, politics have not had any positive impact on the reconstruction of the country. Later on, you know, when I moved to health, I became Minister of Health, it was politics that actually impeded the development. And later on, over the last 18 or maybe 19 years, in addition to bad politics, corruption became one of the major problems impeding any kind of development. So if you're asking me about the political implications of this, these are the two key challenges that many countries face, but particularly in Iraq, that is definitely not only impeding development, but causing a progressive deterioration in basic services. Yeah.
And, you know, I think it's public record that your clash with that challenge of corruption led to, you know, a big decision for you in terms of integrity and what you would do as an individual.
Absolutely. Yeah, that was even more recently, because I was again asked to, with my experience in WHO, to try and initiate a program to fix the health sector, and there were, and one of the major challenges for me was actually to address corruption, because this was impeding any kind of reform, not only in this sector, but in all sectors. My focus, of course, was health. And so there were a number of situations where I had to take very, very strong decisions, and ended by, you know, my resignation. But just not the resignation and giving up, but I also produced a document, a long document, which was published and put on the website of the government website, giving the reasons and what, you know, what the situation was like in trying to address corruption. And the problem with a corrupt political system is that it does not only affect the health sector or the education sector. So it does not only affect the executive government, but it also affects the legislative government. So it's the parliament that is sometimes the source of impeding forces that prevent any kind of reform to take place because of, you know, personal interest or political interest. So that's another contradiction between politics and construction or development.
You might want to grab the metal bit of the mic, otherwise we're hearing a lot of feedback. What you're modestly trying not to say, I think, is that you stood up to that corruption, actually tendered your resignation, they didn't accept it, and, you know, so I think it's a pretty awesome demonstration of integrity in the face of people who have some different values. But anyway, let's move on to the question of health and your role at WHO. Maybe Anna, can you kick us off in that direction?
Yes, thank you. I think my question is about the multi-sectorial approach and multidisciplinarity that you mentioned. And I see in your presentation talking about NCDs goes beyond health, and also making a statement that it's definitely the way to move forward. And why I want to ask this question is because from the research I do, I'm doing mixed methods research, which includes quantitative research and also qualitative research. And I think my background comes or started with biomedicine, and then moved a little bit to public health and global health, and now it's kind of growing on the disciplines of sociology and anthropology, especially on food and diet. So what I say, or what I've seen during these years, is that from the biomedicine point of view, health sometimes is treated as a separate domain from morality, religion, and also other domains which are much broader than what is to be healthy or what it's not. And the reason why I'm pointing this out is because when you mention the surveillance and how do we monitor NCD progress, I think we use a set of specific indicators and criteria which we collect and put on our health information systems to then universally compare the progress that different countries are experiencing with NCDs. I wonder how can we incorporate more different disciplines into this monitoring progress to make sure that we not only capture health from the biomedical point of view, but we also incorporate for example, sociology and anthropology views on this.
Yeah. No, I think it's a very important point. And as I said, I think what you are mentioning is a must now. NCDs is a very good example that you really cannot move forward unless you address the other determinants outside the health. And it's really a global health problem that can only be tackled beyond the traditional health kind of dimension. I think we're moving forward in this because in the monitoring set of monitoring indicators and also in the updated national health information systems in many countries, and particularly in relation to non-communicable diseases, but also applies to other conditions, there are now a number of indicators that are actually indicators that measure areas beyond health. So, education is a very good example, but beyond education, other sectors. So I think this is something that is now accepted. There was some resistance, I think, at some stage to not in relation to monitoring, but in going outside the health sector for certain programs. But I think it's clear from non-communicable diseases, from many other global challenges that we are facing today, that this is the way to go. So I think this is, you will see probably an increasing interest in ensuring that the other non-health indicators are part of not only the monitoring systems, but also in the overall national health information system.
So should we turn to Lambert? Do you want to?
Yes, thanks very much. And Ala, it was very interesting to follow your talk and follow how the WHO approaches NCDs. And what I took from your talk is that one key role of the WHO is characterizing NCDs in order to provide guidelines for nations on how they are going to act in concerted and synergistic ways. And one important thing that comes to mind when we want to characterize things is evidence. The WHO needs evidence, and much of this evidence would not come from the WHO, probably from academia. And I work in African cities, and one challenge we have is data and low research. So inevitably, the evidence that comes from low and middle income countries that help to characterize NCDs are quite low. And if we know that it's from this that we provide solutions or proposals on how to make policies, we already know that the broader policies and recommendations that are made by the WHO are going to inevitably be difficult to implement in these areas where the evidence contributing is low. So my question is, how do you see this playing out? We are in a space where we're using broader recommendations in settings where evidence is always, most of the times, low, and so there's this gap that I see, and I would like to hear from you what you think.
Yes, thank you. One of the challenges we have as politicians, and if I am a Minister of Health, is that we often get recommendations, not only from WHO, but from other organizations. And the assumption for those institutions that develop these recommendations, disseminate these recommendations, that they should be implemented. And if there is no response, then, well, we have made these recommendations and they are not implemented. Actually, many of these recommendations that we make in WHO, in academia, and in other institutions that support countries in addressing major global health problems, most of them are generic. And they're common sense, they are based on evidence, but at the same time, they are too general and too generic to be implemented. They require more evidence, particularly local evidence, but they require also the know-how to address them. So when we make a recommendation, as in the best buys, of reducing salt reduction, eliminate trans fat, for example, increase tobacco taxation. These are very complex issues. You make the recommendations and you assume that countries will move forward. You know, they take the recommendations and they implement it. They don't. Many of them don't, unless they have the know-how, unless they have the evidence. And that is why I think one critical issue today in non-communicable diseases, in health systems, and in many global health challenges is the critical importance of implementation research. I know that so many universities are now having departments or units of implementation research, but they remain too academic and too theoretical. Working in countries, particularly low and lower middle income countries, to try and implement these recommendations, go into the complex process of reducing salt. I mean, it's not just, reformulate or, health literacy about salt and what you should do in relation to consumption. It's much more than this. And so the gap, I think, in low and middle income countries is in the area of implementation research. And on the capacity of countries, we found, in all programs and not just in non-communicable diseases, a huge scarcity of basic evidence. And so we use, in many cases, evidence elsewhere, either regional evidence or international evidence to provide recommendations or to recommend certain interventions. But what is actually needed is to expand the capacity of these countries in health research, and particularly, I would say, implementation research. And I think this is a critical issue that not only WHO, but academic institutions should focus on at working in low and lower middle income countries.
Okay, and finally, Tolu.
Thank you, Ala, for that really great presentation. I wanted to pick on one of the slides towards the end when you're talking about things that you thought impeded more effective response, and I really liked how you framed that out. Can I propose 3, and then I would like to hear your reflections on whether you think, or in what ways you think the WHO could be better fit for purpose to tackle those challenges. So the first I would say is the siloed sectors. One of the advantages we have in health is actually no one disagrees that health is important. You speak to anyone, right? Yeah. But the sectors are so siloed. So you go to a housing sector, they say, well, it's not our mandate. Our KPIs are not health. We know what we do is important, but it's not our mandate. And the framing of how we frame things makes them feel secondary, right? So it's like, well, I've literally heard, why should we do a health job for them? They have a bigger budget than us, right? So there's that siloed governance. The second is a disease framing. So we even talk about NCD financing. But if we reframed it differently as health and threats to health, and coming from different sectors and the key roles that different sectors can play, what would that look like? Because health people know they work in NCDs, right? But Urban Planet doesn't work in NCDs. They don't see that. So the way we frame the very disease framing. And I think the third is universality. And this picks up on both Anna and Lambert's points. In the context where we have a region like Europe where the median age is 42, compared to a region like Africa where the median age is 19. And yet we talk about health in the same way, when actually you have a region where the vast proportion of people are young, and we still frame it in terms of disease and treatment, even though we should be saying, well, actually most people are young, most people should be healthy, and that looks different in different regions and how we frame that. So because of the balanced differential power, if you like, people take what WHO says from up on high without necessarily challenging it and saying, well, this doesn't quite work for our purpose. So can you maybe share your reflections on the ways that potentially, particularly, say, the role of the regional WHO structures and being able to tailor that a little bit more to the context along those three points?
Yes, so I would actually frame it in a way that addresses the priorities of the government official I'm negotiating with. And so if we're talking, about a country situation, very often you need more resources for health. You need more resources for a number of health programs. And you look at the approaches that you could actually consider for increasing the health allocation. And one of them is reprioritizing the government budget. So the government budget should give more to health. But it's not as simple as this, because every other sector is trying to do the same thing. So it's a very tough competition. And so I think what needs to be done is to try and frame your arguments supported by evidence, concrete evidence, that actually responds to the priorities of the sectors you are negotiating with. Very often it's finance sector or the planning sector. And the same thing happened with the non-communicable disease agenda. I mean, we spent about a year trying to look at the evidence of NCDs influencing socioeconomic development. We had a project on the cost of action for NCDs. How much does it cost to implement the best buys? And the cost of inaction. So if the situation remains as it is now, what does that mean to socioeconomic development? And then you look at the figures and see, and these are published. And that is actually what made these ministers who are outside health, get interested in or pushing for some sort of a more effective approach to address non-communicable diseases, because the return of the investment in non-communicable diseases will have a reflection on socioeconomic development. And I think this is what we should do. I remember we had a meeting about 4 years ago in Addis, and this was a global meeting or a regional meeting on immunization in Africa. And we started giving this kind of evidence at the beginning of the meeting. The meeting was attended by ministers of health, ministers of planning, and ministers of finance. And so we gave the evidence that why should you invest in immunization? What is the return for this investment? And then, in the discussion, one of the ministers of health, planning actually, of the ministers of finance, said, I wish my minister of health had actually given me this evidence, because it's absolutely clear that we should give a higher priority to immunization. We should never compromise the funding of immunization programs. And so I think this is the way to go. And increasingly, again, based on your question, that I think this is the responsibility of the health sector now. So the health sector cannot influence policies in other government departments, but can coordinate, can help in influencing policies through this kind of approach.
Can I ask a wild card question building on all of that, to say, because you were in the WHO and now you're not at the moment. So if there was one radical thing that you think, if you had your way and there was no constraints you would do, what's the one most radical thing that you think that you would implement in the WHO today, if you could?
What immediately comes to my mind are two things now. One is to make sure that more resources are given to countries. And so within the WHO budget, I would definitely reconsider the distribution of resources across programs and across levels. That's also related to your question about national, subnational, and regional, and then the global. I think the WHO has 3 levels: the country level, the regional level, and then the headquarters or the global level. And so countries should have stronger WHO programs, particularly in low and middle income countries. And the second thing that is actually needed now is to strengthen the technical capacity of WHO in some critical programs. So again, going back to politics, people should not be appointed because of political reasons. People should be, at least, politics is extremely important everywhere. And I think a good leader has to have some political skills, but definitely has to have some good management skills. But for WHO, the specialized agency of the UN that is leading a number of very important global initiatives, I wouldn't say just health initiatives, like the pandemic, for example, you need a much stronger technical capacity given to WHO. And that, I'm not saying that WHO is not doing this because they are not doing this. They don't want to do this, and they are too political. I say this because the world has to do 2 things in relation to strengthening WHO. One is to monitor WHO's work more effectively, but more importantly is to provide the funding for this organization to operate more effectively. So these are the 2 critical things that I think should happen in the reform of the organization.
Okay, Jane, did you want to ask a question or say something? I wasn't sure. Okay, well, maybe we were going to open it up to the audience, but I'm conscious that formal hall starts in about 7 minutes. So, okay, so why don't we take any burning questions from the floor, if there are any, and if you do the Cilla Black thing of saying who you are and where you're from when you grab the mic. So, yes, sir.
Thank you. My name's George Carrow-Jones. I'm a medical student from Wolfson College. I think one level that you alluded to, one level of government or governance was the corporate sector. I kind of was struck by when you were talking how similar the issue seems to be in terms of climate change, which is you can create a number of funding pots to try and implement solutions on the ground. But the one area that the governments have very little influence over still is the corporate sector. And you still hear, the CEO of Coca-Cola will be lobbying in every speech against sugar taxation, even though it seems to have wide public support. So I'd like to hear your thoughts on what the WHO can do to kind of get better control over, I guess, corporate actors, whether there's anything that can be done. And now in your, I guess, post-WHO role, you can maybe speak more freely about whether there were issues you experienced during the time about corporate interest within the WHO.
So one of the things we did during this journey was to establish a more effective communication with the corporate sector, and as I said when I was talking, that the focus was on three sectors: the diet and nutrition industry, the drug industry, and the alcohol industry. And so what we aimed to do was to try and open communication. There were some people who were actually against even engaging with the alcohol industry, but eventually I think we managed to have a very useful partnership that resulted in the development of the global strategy on the harmful effects of alcohol, with actual representation and engagement of the alcohol industry. And so opening communication channels and dialogue, and we did this through periodic or regular, what we called roundtable meetings. So we have a roundtable for the key industry representatives in any of these three areas, and then we addressed areas very often related to conflicts of interest, where the interests of the corporate sector do not match with the public health targets, and how we can address these. And in all cases, the result was a number of commitments made by the corporate sector. The problem is in fulfilling these kinds of commitments and in continuing this kind of dialogue, because the private sector is absolutely essential in any health program and any development program, and you cannot depend on the government in delivering basic services. I mean, in countries, in many low and middle income countries, the private sector delivers 70% or 80% of primary care services. So you cannot remove the corporate sector from this. So opening channels and dialogues and agreeing on some commitments, but a more effective monitoring of commitments. And as I mentioned, one of the things that we really wanted to do, and it's some sort of a process that's still ongoing, is to develop some sort of an accountability framework. So if you are going to make these commitments, for example, in relation to diet in reformulations, then in marketing, particularly for children, then let's have some sort of an accountability framework that we could use to monitor these commitments and then maybe advance even more effectively to have additional commitments. So I think the corporate sectors, as I said, is an extremely important stakeholder. And it is the conflict of interest, and what we actually see in terms of opposing forces is very important. And frankly speaking, it is not just the corporate sector, but it's some governments that protect certain interventions from being, implemented, and partly because of the industry influence.
You might be talking about our government, but maybe we'll pass on from that. So there was, I think, one final question over there. Yeah. Yep, please.
Hello, good evening. Thank you so much for your talk. So I'm Nazneen. I'm an MPhil student in Population Health Sciences and Global Health. So my question is related to the comment that you made about recommendations being too generic, often for countries. And within that context, I'd love to hear your thoughts on this idea of community engagement and involving people living with non-communicable diseases in policy and decision-making processes. I know WHO is developing a framework for the meaningful engagement of people living with NCDs in policy-making processes. Would love to hear your thoughts and what are some of the barriers that you see in implementing this.
Okay, I'm going to be Paxman. So it's a great question, but you may have to give the brief answer, okay, because we're up against time a bit. Sorry, Alan.
Yeah. No, I think in non-communicable disease, I don't think we have great experience. But in certain other programs, like programs on universal health coverage, this is absolutely important. And I think, because a number of the key interventions in many areas, particularly maternal and child health, reproductive health, communicable diseases, the community interventions are very critical, and they constitute a major part of the package of essential health services that is needed for universal health coverage. I think if you look at the best buys, I think for non-communicable diseases, the work that has been done in this area has not been very, very effective.
Okay, so I think we better wrap it up now. I just want to thank Tom and the Science Society for helping to co-host this evening, and to Rosemary, who's not here from the Global Health Hub. But she's got a good excuse, getting married tomorrow, so she's otherwise engaged, so to speak. Particularly thank you all for coming. But most of all, thank you to our panel members, but obviously to Ala. We're very honoured to have you here, and it's been great, so thank you for coming up. Thank you.